I started incorporating genetic testing about 2.5 years ago. I felt like that was the next generation for me to give me some insight and guidance on the patient's inherent risk factor for developing any sort of post-surgical corneal laser vision correction ectasia. Because I see so many patients for the management thereof, as well as primary ectasia, for me, it makes me even more cautious. And so I feel like I'm a little bit conservative in who I will do laser vision correction for. So if I see a patient that may have some irregular astigmatism or anything that makes me pause and wonder, for example, that central bow tie or steepening on the topography, or some other factor that I see in maybe 1 in 5 evaluations, I love utilizing genetic testing to help me in that scenario. And then, of course, for my keratoconus subjects, I'm getting patients sent to me for progressive myopia, progressive astigmatism, those who are younger patients. And doctors want to know, is this just their natural myopia and natural prescription that's progressive? Or is it because they've got an underlying disorder? And living in Virginia, we have perennial allergies all the time. There's so much eye rubbing. All of those things, it helps me really guide and put together all the information that I need to determine what I need to do. It gives me that extra little oomph and confidence in this plan for my clinical patients. So when the patient polygenic risk score comes to me as either very low or in the high realm, okay, that makes it very easy. It's the middle that can get a little bit more confusing, particularly for me, even though I don't quite know yet with certainty because only data and more evidence with the natural progression of these patients will give me a better understanding. But if it's like a 50, okay, and higher, for myself, if it's someone who is suspicious, that is suspicious enough for me to say yes, that follow-up for the patient, if they're a keratoconus suspect, should be sooner. Or I'm certainly going to recommend doing something like collagen cross-linking in order to help stabilize them, because that plus their other risk factors is enough for me to say, let's go ahead and get them treated and see them sooner. If it is someone who is a refractive surgery evaluation, for me, it's not even worth going down the route of laser vision correction. Now that we have EVO ICLs available and I'm able to mitigate doing that peripheral iridotomy, I'm suggesting and recommending going straight to EVO, which will help, there's going to be less dry eye or no dry eye and no chance that I could potentially cause them to have a post-LASIK or post-PRK ectasia. For someone who's 50 or less, and let's say they're a refractive evaluation, if they're not too myopic, maybe -5 or less, and they've got otherwise good corneal parameters, I will say I'm okay with PRK, but they are at a slightly higher risk. I may have to cross-link them. We can decide to cross-link first or cross-link later, and I don't have enough evidence yet which way to go, but no eye rubbing. They have to make that social contract with me of no eye rubbing. And then if it is a keratoconus suspect, then I will have that patient follow up with me maybe in 6 months for interval testing and interval manifest and looking at that information. And if they're low, obviously, I'm able to push them out a little further or send them back to their referring doctor. I think genetic testing is truly going to be the future of providing another piece of essential data in the diagnosis and management of various disease processes where we know that genetics plays a role. Keratoconus and other corneal dystrophies, other processes where we know there is a genetic component. Glaucoma is another example. Macular degeneration, I think there's so much to be unearthed that we just didn't know before. And with better treatment availability, all of this and being able to take care of our patients earlier is why we do it. And right now in the realm of AvaGen with keratoconus and ectasia screening, it is tremendously helpful for giving me a little bit of that extra information so I know how to plan for their follow-up, whether I can wait or if I should act and intervene And for my refractive surgery patients, I know which route I can go. And this helps me in my evaluation patients. I always say the good news is I know you are a candidate for refractive surgery. What kind of refractive surgery is what we have to figure out. We can definitely place sort of a contact lens that will permanently fix your vision in the eye, but it is something that is a little bit more costly and requires you to go to the operating room. We can consider other options, but I don't know if they're right for you. I do want to check your genetic information because that data will help me determine what the right pathway for you is. And that really helps in terms of at least providing some level of overall prognosis for our patients and insight so they know guidance-wise which way that they will go and what their future looks like for them, for the reason as to why they came to see me in the first place. With genomic testing overall, I do hope that it's going to help us to better diagnose the potential progression as well as stage our patients for what we need to do clinically in follow-up with our patients. For example, let's take glaucoma. I really think that this is going to be so helpful. Even if you look at, for example, the 5-year Hydra study, it demonstrated that if you looked at all these patients who were mild stage glaucoma, you didn't know just by looking at their nerves in 5 years who was going to be a fast progressor, who was going to be a slow progressor. I know that genetics plays a role in this. So this is going to really help me gauge whether they should be topical medication, whether an intervention should be more surgical, and it guides me as to where we should put their risk, whether they're low risk or high risk for progression. And it gives the primary doctor just greater insight as to whether or not they should be referred out or kept in-house for management. So that's just a really clear example where I think genomics is going to be so important in eye care and in the future of just medicine in general. With regards to genomic testing and where we are, I really do want to say thank you to AvaGen for demonstrating that there is strength and understanding that inherent information, and it has helped me with my own confidence in determining those patients who are keratoconus suspects or for my refractive screening patients, so I know how to more confidently help with their clinical management and planning. With that being said, the true aspiration is to figure out the therapeutics. Using genetics to help guide us in therapy is really where we need to go in that next generation. And I see that this is where it's going to go. And true therapies to stop or reverse really devastating diseases, especially of the eye, of vision. I can't wait to see that happen. And I really am hoping that that's already in the works and we'll see that in the next 5 to 15 years.